All right. So when it comes to back to viruses, we often struggle, and I don't have the screen up yet. I haven't shared my screen yet. We often struggle with knowing like what we need to categorize with our viruses compared to bacteria. Because bacteria, we have gram stain, we have morphology, we have these really like clear-cut things. For viruses, you can classify based off of genetic content. So like DNA, RNA, single-stranded, double-stranded, and I would encourage you to do so. So you'll see up at the top, I'll have some like kind of big summary slides that are great to study from. But then really recognizing your viruses and their families and what diseases they cause is going to be your best bang for your buck when it comes to virology virus questions. And we'll have a couple slides at the beginning that talk a little bit about virus life cycles and what make viruses different than bacteria, because they do have some differences. And we'll even see that when we talk about the immune system. The immune system responds to viruses in a slightly different way than it responds to bacteria. So we'll look into some of these pieces of the puzzle here in this next section. So getting into our virology. All right. Our beautiful viruses. So generally, some general features of viruses is they'll have either DNA or RNA, but they will not contain both. The nucleic acid, the DNA or RNA, is surrounded by a protein shell, a capsid. And some viruses then also have a membrane-like envelope surrounding the particle that can contribute to their virulence, their ability to divide and replicate, but others will not. Viruses also are specific because they cannot live independently of other living cells. They cannot undergo cell division as prokaryotes and eukaryotes can do. So they have to live intracellularly. They need other cells' machinery to divide. Our DNA viruses tend to be larger, they tend to be enveloped, and they tend to replicate in the cell nucleus. So we tend to see these kind of general themes for our DNA viruses. They can also cause latent infections. That's a component that's more unique to a DNA virus than an RNA virus. RNA viruses can be single or double-stranded. They can be negative or positive sense. And what I mean by that is negative sense must use RNA polymerase to produce a complementary copy before coding for the protein, versus positive sense can just directly code for the protein. But negative sense, they have to replicate that, that strand of RNA first before they can do their protein encoding. The copies of RNA, just like when we would normally do our process of translation, are produced in the cytoplasm. So we are not in the nucleus for RNA virus replication. And then the last category is retroviruses. And these are often single-strand RNA viruses who first must produce DNA, hence the retro, before they can actually replicate. And they use their own reverse transcriptase to do so, and they tend to be enveloped as well. So these are general things you can apply. Anytime you hear me say DNA virus, think larger enveloped cell nucleus replication, latent infection. RNA virus, think single or double, negative or positive sense, cytoplasm. And retroviruses, they use their own reverse transcriptase and they're enveloped. Looking at these different processes, this is just a beginning kind of categorization. I don't find this too helpful unless if you know like the prefixes for bacteria, for viruses and their categories, but essentially it's broken down the viruses into their categories by prefix and showing what their genome type is, and then what their mRNA to protein process would look like. So the only ones that are super duper helpful is maybe like herpes virus types. You could see is double-stranded DNA. So then mRNA to protein. Parvovirus is your single-stranded DNA. Your coronavirus, your positive sense RNA. Rhabdo or proximovirus is your negative sense RNA. And then we have retro, your retroviruses, and then Rio, your double-stranded RNA. But again, if you're not a virologist and don't have these memorized, which I wouldn't expect you to, this probably template isn't as helpful. This one could be more helpful. This, again, though, it shows the family name of the virus, shows if it's double-stranded, single-stranded, positive sense, or negative sense, if it's RNA or if it's DNA, and then if it's naked or enveloped. and then the type of capsid that it has, if it's icosahedral or helical. So this one, again, if you know family name, can be very helpful. So as you're going through, it might not be a bad idea instead of family name to put the actual virus name and disease in these categories below as you study, as a study tool. Again, this is just more, like I said, these are different study ways to look at the same exact information. So other charts that are just showing RNA versus DNA viruses that are medically important. Now, when it comes to the infection cycle of viruses, animal virus infections can either be lytic or lysogenic. And in a lytic infection, we'll see the host cell will fill with virions, as so, and then burst, lyse. The result will be cell death with lytic. Lysogenic cycle, lysogenic infections are also known as latent infections. The viral genome will become incorporated into the host cell's DNA, and it can remain this way for a long, long period of time, and the host cell can live as long as it remains this way. When we have excision of that viral genome from the DNA and then replication, then we move from the lysogenic cycle to the lytic cycle, and then the cell will eventually die. But we can live in this latent phase for a long period of time. And this is just showing our viral life cycle of replication. We see that there's 6 different parts here. We can see that there's attachment here, then penetration into the cell, uncoating of the outer envelope if needed, biosynthesis, so replication essentially. So we have transcription, protein synthesis, replication. This could be, I guess we could associate assembly as maturation, and then lysis and release here. So this is showing you 9 steps. I kind of put them in 6. You attach first, you get inside the cell, you uncoat the stuff, you do whatever your biosynthesis is, because it'll look different depending on if it's DNA or RNA or a retrovirus. Then you mature by putting all the things together, and then you're going to release, typically by lysing. And this is that bud, that releasing. Another showing a couple different examples of ways that we can fuse. So we can see here an enveloped virus is going to go in oftentimes via endocytosis. Potentially, you could see fusion for small viruses that are not enveloped. They can just move directly in. And you can see pinocytosis as well for these non-enveloped viruses moving directly in. So fusion, they're actually the outside is becoming one with the plasma membrane. Endocytosis for enveloped viruses, and pinocytosis for non-enveloped viruses. That's what this picture is showing. 3 entryways: fusion, endocytosis, pinocytosis. So now we're going to go from like the general, we're going to go look at specific categories and groupings that we've made of viruses to try to make it easier for memorization purposes. So we're going to start with our 6 childhood exanthems. These are our classic exanthems. We have pretty solid etiologies, and so they're named actually by the number. So we have 1st, 2nd, 3rd, 4th, 5th, 6th, and then we have their actual name, and then we have their etiology. So measles, scarlet fever, which is actually a bacteria, rubella, Duke's disease, which is no longer accepted as a distinct disorder, erythema infectiosum, and roseola. And so we're going to look at measles, which is rubella, erythema infectiosum, and roseola infantum. So we'll look at these 4 because scarlet fever is a bacteria. So rubiola, which is measles, it is an RNA virus of the morbillivirus in the family Paramyxoviridae. My goodness. So when we're thinking about this, we can say, okay, so rubiola is an RNA virus species. Its genus is morbillivirus, and its family is Paramyxoviridae. And remember, our kingdom, phylum, class, order, family, genus, species. So family is just one up from genus, just a slightly bigger class than what we've been looking at for our bacteria. Bacteria, we're really looking at genus and species. In viruses, we're going to look at family, genus, species, oftentimes, for categorization. So the epidemiology, prior to vaccination, you would see it among 5 to 10-year-olds. It is very transmissible, it's very contagious, and it spreads via droplet transmission during the prodromal period. So the prodromal period is day 7 to 14 after exposure, and you'll see the 3 C's, cough, coryza, and conjunctivitis. Also Koplik spots, which you can see present in the mouth here. That's 1 to 2 days before the rash will appear. And the rash is a descending maculopapular rash that starts kind of behind the ears, and it includes the hands and the feet. And miserable. These kiddos are sick. Hence why we do have vaccination now. You can kind of see the course and prognosis here on this right side in this picture, but it's typically self-limited in most patients. Complications could occur in children that are malnourished or have an immunodeficiency or are already sick with something like a leukemia. Complications, you can see complications in kind of all the different organ systems depending on what gets targeted. One chronic complication to note is subacute sclerosing panencephalitis, or SSPE. This actually could occur years after infection. It's relatively rare now, but it is the complication that I would put in my notes to associate with measles. And you can detect IgM from measles 1 month after the illness, but sensitivity is not great. And so we can kind of see here incubation period and then disease period, and then antibody titers kind of show up a little bit later on. Okay, that was our rubeola. So we can see here, measles, rubeola. Now we're going to rubella, which is German measles. So that's when we kind of start getting things confused. This is also a common benign childhood infection. It has a classic exanthem as well as lymphadenopathy. It's an RNA virus as well. It has a genus of rubevirus and a family of tocoviridae. So different family, different genus. It's spread again by droplet transmission, or it can be spread through the placenta to the fetus. And it's pretty, again, peak incidence 5 to 14 years old. Incubation period is 2 to 3 weeks. And you'll see more of a mild catarrhal symptoms of things draining. In adolescents or young adults, you could see low-grade fever, mild URI symptoms, and oftentimes the real big thing with rubella is the lymphadenopathy. So posterior cervical, posterior occipital, and retroauricular lymphadenopathy is our characteristics of German measles or rubella. The rash will start on the face and spread to the trunk versus, remember, the classic rubeola, the classic measles, the rash starts behind the ears and spreads downward, and it does not spare the hands and the feet. It's on the hands and the feet. This one starts on face, moves down to trunk. This is a good time to just mention torch. So for most people, rubella is really mild, but pregnant females that are infected in their first try can pass the infection transplacentally. And this is why we test for immune status for rubella on a prenatal panel. Because if a pregnant mom gets infected for their first time with rubella, they've never been infected before, they don't have any immunity, and and it happens during their first trimester of pregnancy, you can see what's called congenital rubella syndrome, where you can have congenital heart defects, cataracts, microophthalmia, deafness, microcephaly, and hydrocephaly. So essentially a whole host of birth defects for the kiddo, some that may not be compatible with life. And we'll see a couple other instances of torch coming up, and there's a couple other viruses to watch for, but this is one of the classic ones, is rubella, which typically is a relatively mild disease, but in this grouping of pregnant females, it's not the female that has it bad, it's the fetus, the developing fetus. Now, Fifth's disease. So remember, we talked about classic measles, rubeola, that's first. Then we talked about German measles, rubella, that's third. We skipped fourth, now we're on fifth disease, which is erythema infectiosum. This is caused by parvovirus B19, and it's a single-stranded DNA virus. This is our first DNA virus. It's in the family Parvoviridae and the genus Erythrovirus. So a similar family, but a different genus. It looks like slapped cheeks, the rash does, on both sides, and has this erythematous lacy eruption on the trunk and the extremities. It's also spread by droplets, so all of these so far have been. Kind of general symptoms for children of like a URI. Adults could have more severe symptoms, so you could see actually arthritis or arthralgia to smaller joints, even numbness or tingling of fingers. So kiddos typically have it easier with this condition. And in a patient who has essentially hereditary hemolytic anemia, you could see this being associated with an aplastic crisis, like a sickle cell anemia type syndrome or a sickle cell crisis in someone who had a hereditary hemolytic anemia and then developed erythema infectiosum. Then roseola infantum. This is our last childhood exanthem we'll look at. This is associated with primary HHV 6 and HHV 7, so our herpes virus 6 and 7. It's characterized by a sudden appearance of a rash and high fever in a healthy appearing infant. The rash will start on the trunk and move over to the face and the extremities. So kind of the opposite of rubella that started on the face and moved down. This starts on the trunk and spreads out. It's a primary infection, can be acquired from oropharyngeal secretion. And you can see a lot of different like blanchable macules, papules in the back of the febrile child. It'll appear as the temperature starts to fall back down to normal. So if we look at these four, rubella, rubiola, roseola, and erythema infectiosum, we can see the etiology, the specific virus that is actually causing the condition, our incubation period, who it's really affecting. The rashes are all maculopapular. Where the distribution is can help you often tell these apart, and any prodrome, which for some is really nothing, and for others can be more severe. So this is my favorite study slide for the viral exanthems, at least the four that we talked about in this class so far. This can show you some other additional components. I don't find this as helpful. I think it's a little bit more detailed than I want it to be, but nonetheless, it shows fever pattern, infectivity, and rash. And then if you're a visual person, rubiola, which is your typical measles, rubella, your German, and roseola infantum, exanthem. So you can kind of see the differences visually here with these three different conditions. Okay. Any questions about the exanthems before I move on to mumps? Okay. Just thrilled about the exanthems. They're pretty fun. They're almost always on the boards in some way. So, all right. And mumps often is too. This poor little kiddo. So myxovirus parotitis is an RNA virus as well. So we see a lot of RNA viruses so far. The source of infection can be respiratory. It could even be transmitted via the milk. And the name comes from the British word to mump or to grimace or grin. The appearance is that parotid gland swelling. It seems to almost cause like a grin, but it's just the parotid gland that's swollen. And our clinical features, we'll see parotid swelling. You could have potentially itis or swelling in many other organs. The one that oftentimes is like tested or brought up is orchitis. So that's another kind of clinical feature potentially that you could see come up. It could lead to an aseptic meningitis. It can, because of the orchitis, cause sterility after puberty if not caught early on, or if it's spread or was infected too bad. So it is a reason that we obviously want to be vaccinated for this if possible. There is a vaccine for it. But the virus enters via the respiratory tract. It grows in salivary glands and lymphoid tissue. It can spread to the spleen and distant lymphoid tissue. It can get into the blood and spread throughout the system. And it will target testes, ovary, pancreas, thyroids, and salivary glands. That's like the kind of main portions of the disease. So then thinking about these viruses that we've learned so far, which of the following viruses causes an acute febrile rash and produces disease in immunocompetent children, but has been associated with transient aplastic crises in persons with sickle cell disease? Ooh, we looked at this one kind of towards the end. Is it rubiola? Is it varicella zoster? Well, we haven't looked at that yet, so probably not. Is it parvovirus, rubella, or herpes simplex? Which one? Is parvovirus. Our parvovirus, which was our parvovirus B19, that is typically pretty much, it can produce disease like a acute febrile rash first, and then has disease in immunocompetent children, but that aplastic crisis in sickle cell disease, that hemolytic uremic syndrome and sickle cell disease, that's your parvovirus. So a 3-year-old child presents to the physician's office with symptoms of coryza, conjunctivitis, low-grade fever, and Koplik spots. The causative agent of this disease belongs to which group of viruses? So we all know it's measles, right? We know it's the classic measles, rubeola. So now what's the group? Is it adeno, herpes, picorno, orthomyoxo, or paramyoxovirus? When these groupings matter. Is our paramyoxovirus group. So here's an example of how NPLEX could use a presentation to get you to test for the family or the genus of a virus that you already know. An obstetrician sees a pregnant patient who was exposed to rubella virus in the 18th week of pregnancy. She does not remember getting a rubella vaccine. What's the immediate course of action? The best one: terminate, order rubella antibody titer to determine immune status, reassure the patient because rubella is not an issue until after the 13th week, administer rubella immune globulin, administer the rubella vaccine. Our best immediate course of action. Absolutely order the titer. So we check the titer to see if immune status, and then from there we would go on and decide what would be the best course of action. But this is not a treatment test. So kind of when you have these questions, they're probably not expecting you to know how to treat things, but this does kind of fall under like that public health epidemiology knowledge base. So this could be an answer and a question asked on a NPLEX I. Mumps virus accounts for 10 to 15% of all cases of aseptic meningitis in the US. Infections with mumps is apt to recur periodically in affected persons, will cause mumps orchitis in post-pubertal males, is maintained in a large canine reservoir, usually produces severe systemic manifestations, is preventable by immunization. And it is E. It's preventable. So there's no reason why we should be seeing cases like this, because it is a preventable condition by immunization. All right. So we're going to move now into our next category of viruses. And so we're actually going to look at a family, our herpes viridae family. And we can see that there's alpha, beta, and gamma subfamilies that then break down into our genus and then our species. Now, when we think about the viruses that we know, we often know them by their species, but some we actually know by their genus. So some that we know by their genus is cytomegalovirus. We know that based off of its genus, versus species like HHV1 or 2 or varicella zoster, VZV, we know based off of its species. So we'll kind of go back to and refer back to these this image or this picture to help us be able to place these. These are all going to be the family of our herpes viridae viruses. We also see that our viral exanthems that we initially looked at in our first kind of set, HHV7 and 8, while they're herpes viridae viruses, they're unassigned in this category. So they are not given an alpha, beta, or gamma group, which is why we often don't necessarily include them in this discussion. We included them before in our viral exanthem combo. Okay. So some general properties of herpes viruses. They are enveloped double-stranded DNA. The genome has long and short fragments. There's multiple different isomers, and there's 3 subfamilies, like I mentioned. They are set up latent or persistent infection following a primary infection, so they can do that latency piece, being a DNA virus, like we talked about, DNA and enveloped. And reactivation is more likely to take place when you're immunosuppressed, which makes logical sense. We've seen that with some of these viruses before. So we'll delve in. Both primary infection and reactivation typically are more serious in immunocompromised patients. They are less serious in patients who are immunocompetent. All right, so HHV1 and 2, or HSV1 and 2, herpes simplex virus 1 and 2 is spread by direct contact via mucous membranes as the virus is shed in saliva, tears, genital, and other secretions. There's 2 peaks of incidence, the first in 0 to 5 years, and the second in late teens when sexual activity starts. Generally, HSV1 causes infections above the belt and HSV2 below, but it's not a perfect system. 40% of clinic isolates from genital sores are HSV1, and 5% of strains isolated from the facial area are HSV2. So it's really complicated. It's not a clear-cut picture. Following a primary infection, 45% of orally infected and 60% of genitally infected herpes patients will have recurrences of symptoms. And the frequency of recurrence will vary. It'll really vary on like stressors, triggers, so many different factors, underlying diseases, immune status, so much more. But the pathogenesis of this virus during primary infection, HSV spreads locally and has a short-lived viremia where the virus is disseminated throughout the body. The spread occurs to the trigeminal ganglia, all the way here for HSV1, and the sacral ganglia for HSV2. Hence why they tend to be associated in these different places, right? Trigeminal nerve, trigeminal ganglia up here, coming off of our cranial nerve 5, trigeminal nerve, and then sacral ganglia coming off the sacrum. The virus will then have latency in that ganglia, and if it gets reactivated, it can provoke a reoccurrence. And we have lots of different things, like I mentioned, that can reactivate. And when it reactivates, it can we can see the pathogenesis present exactly how it presented the first time. In this instance, probably HSV1. We can see that site of viral latency and then the site of the active lesion at the end of that kind of nerve chain. So HSV has lots of clinical manifestations. We can see some that are common: herpes labialis, a cold sore, ocular herpes keratitis, obviously more dangerous, herpes genitalius, like a typical herpes lesion on the genitals. And you could even see temporal lobe encephalitis. This is the most common cause of temporal lobe encephalitis, is HSV, and neonatal herpes. So a moment on that, since it's the most common cause. One of the most serious complications is herpes simplex encephalitis. Neonatal form, there is global involvement and the brain's almost fully liquefied, so the mortality rate is 100%. For focal disease, the temporal lobe is most commonly affected of all the other lobes, hence partially the name. This form of the disease appears in children and adults, not neonates, and many of these happen from a reactivation of the virus. The mortality rate for this is very high, about 70% without treatment. It's really important, if this occurred, if you suspected this, to make the diagnosis early. And IV acyclovir is given as treatment in almost all cases of this, even before laboratory results are available. So there's treatment that's applied before confirmation. Okay. It is rare to have this complication, but it is the most common cause of this complication. Varicella virus. So our virus that's thought to gain entry via the respiratory tract and spreads to the lymphoid system. It'll incubate for a couple weeks and then it'll arrive at its target organ, which, as we know, is the skin. I have my wonderful chicken pox. You can't really see it, but I have a little scar from when my chicken pox when I was little and scratched it a lot as a kid. I was prior to the vaccine. So there you go. That ages me a little bit. But following primary infection, the virus will remain latent in the cerebral or posterior root ganglia. And then about 10 to 20% of people, you'll see a single recurrent infection that will occur after several decades, which comes up as shingles. The virus will hang out and then reactivate in the ganglion and track down the sensory nerve into the area of the skin innervated by that nerve specifically. And then it'll produce that varicella-form rash in the distribution of the dermatome. And so that's the classic shingles presentation.
Dr. Petcho?
Yeah.
I don't know if this is important for NPLEX. I'm just curious, what are some of the factors that will like predispose someone to getting shingles? And then also in those people, like, have they identified triggers? Is it kind of like the same as like HSV1, like stress and all that kind of stuff?
It typically is the same kind of pieces, like stress, underlying conditions, underlying other infections, actually, things that take hits on the immune system. That seems to be the most common triggers that we've agreed upon. But some people are just set up to be more unlucky, I guess, or more likely to present with shingles later on down the road, later on in life. Because there are some patients where they'll present even with an early onset of shingles, don't have relatively a lot of triggers, at least that we're aware of. And other patients who maybe you would expect would present with shingles or be at higher risk who don't. So we say that it's like the classic trigger, like HSV1, HSV2 type triggers, but it doesn't always align that way with the shingles presentation or reactivation of VZV.
Interesting. Thank you.
Yeah, and there is shingles vaccine, which can help prevent a shingles reactivation. It just provides your body with additional memory so that it reminds your body, like, what is this virus? How do I fight it? So if the virus does try to reactivate, the body can potentially nip it in the bud before it develops into a full-blown shingles reaction or shingles infection. And so that's why the shingles vaccine does exist. And that's why they recommend people who have been vaccinated for chickenpox to actually get the shingles vaccine as well. So there is like this component where it still is a little tricky to predict fully when a shingles episode will arise. But it is extremely painful. From my patients I've seen who have had shingles, they are in some of the worst pain that I've seen from like a topical skin condition. Yeah, it's pretty impressive.
Thanks.
Yeah, awesome. Good stuff.
Are shingles typically like, will you if recur, like if once someone has it, do we see like an increase in recurrence in those people typically, even with the vaccine?
Typically, it's a one-time says all, but it can reoccur. And I have had a few patients that have had a reoccurrence. It's more rare. And those are typically your patients who are more immunocompromised or very high stress or have other lifestyle factors that are contributing to why their immune system is suppressed. Yeah.
Thank you.
Yeah, awesome. Perfect. So when we do see varicella, so we'll start back to chickenpox. The primary infection for varicella zoster virus is your chickenpox infection. You have that 2 to 3 week incubation period. The widespread vesicular rash is by and far the like classic presentation piece. Typically, you can make these diagnoses on clinical grounds alone without needing to test. And complications typically aren't seen with children, but are seen with adults. Adults and immunocompromised patients typically don't do as well with chickenpox. And that's why there's kind of the joke back in the day is you always wanted your kids to get chickenpox when they were young before they turned like 10 or hit puberty. And so there'd be pox parties or, all these things because it is true that complications are more likely as you edge towards adulthood. The most common complication is a secondary bacterial infection of these vesicles. There could be severe complications. Typically, this is not seen. These are more rare, but obviously any of these things, since it's viral spread or respiratory spread, you could have a pneumonia. Anytime you're dealing with a viral infection that gets viremic throughout the body, encephalitis, and hemorrhagic chickenpox. If you started seeing bleeding or issues with blood vessel involvement or capillary involvement, you could see hemorrhagic chickenpox. But again, these are very rare complications, things that I wouldn't put into your brain. Here's our shingles. Here we can see the virus, that nerve, and then that dermatome affected. It's going to affect one dermatome of the skin. So if your patient says they have bilateral shingles, they do not have bilateral shingles. It's going to affect just one dermatome. It can occur on any age, but majority are typically after 50, although we're starting to see that age creep down now more and more. The virus that was latent becomes reactive in a sensory ganglion and tracks down that sensory nerve to the appropriate dermatomal segment on the skin. And you'll have a classic eruption of vesicles in the dermatome with intense pain, and it can last even months after the rash subsides, and that's post-herpetic neuralgia. One of my first actually homeopathic cases of success where I saw homeopathy work was on a post-herpetic neuralgia patient who had tried everything for her post-herpetic neuralgia, and hypericum homeopathic, of all things, was what worked for her. So it was surprising. It's like a 2-year post herpes zoster shingles. So good case. As though the same thing with varicella, herpes zoster is way worse for immunocompromised patients. Reactivation will occur earlier. You can have multiple attacks, like I mentioned, and even more complications. Complications, you could have encephalitis, again, like the classic kind of things, encephalitis, pneumonia, disseminated disease, like those are going to be my common strains for all of these viruses. All right. Now, my other torch, I told you I was going to bring up another one. So is our congenital VZV varicella virus infection.
Quick question.
Yeah.
Shingles, are they very communicable? Are they contagious?
It is contagious. It's contagious though as varicella zoster. So it's contagious via respiratory droplet spread, typically not from contact on the vesicles, although chickenpox can spread via vesicle touch. So in theory, shingles could too. So yes, I would say highly contagious.
I'm getting mixed results on the Google search, so.
Yeah. Yeah,
sure.
typically we say contagious, but it's questionable on how contagious like the vesicle actual fluid is versus
Right.
it's typically spread via respiratory droplet. So we typically count our shingles patients as contagious. We try to isolate them away from other patients. But oftentimes as docs, we're not necessarily worried about catching shingles from our own patients when we see them, if that makes sense. It's kind of mixed messages.
Yeah, I'm just a little confused why they're spread through respiratory droplets if it's like affecting a single dermatome.
Well, so it's because the original virus is the virus that causes varicella, right? That causes chickenpox. So
Yeah.
the virus itself gains entry through the respiratory tract, spreads from the respiratory tract into the lymphoid system, and from there tracks through to the skin. So that's why it has this like long latency period. From
I see.
there, so that's the kicker is the virus itself, when you're having the reactivation, you didn't get re-exposed. Your virus that was just hanging out in that ganglia got reactivated. But the original source of the virus was respiratory tract droplet spread. So that's where the droplet precautions comes into play with chickenpox. But the vesicles themselves were thought to also be able to spread disease, which is why we keep kids away from each other, and that's the pox party, that whole business. The
Right.
question is with shingles, the vesicles are there, but they're not quite the same as chickenpox vesicles. They're not as itchy and scratchy. They're more painful and hard. And so can there be spread from contact? Probably, but it's likely less contagious than what we'd see in a classic chickenpox presentation, if that makes sense.
Yes, great explanation. Thank you.
Okay. Yeah, totally. Thanks for walking down that road with me.
I have
Appreciate
another
it.
question. Sorry.
Yeah. No,
It's
please
more
do.
about like timing now. I'm just kind of trying to make sense of it. So
Mhm.
when you get the infection, you have the incubation period of 2 to 3 weeks.
Mhm.
During that time, would they be asymptomatic? And
Yes.
then after that is when they would have symptoms once it's kind of like gotten root and then kind of activated in that sense. Okay.
Yes.
They
And
probably
so during their time of like inoculation, incubation, they could be infectious to others and not be displaying symptoms.
Okay. And then
Mhm.
once they are displaying symptoms, how long does that usually last? And are they like still contagious and infectious during that time period as well?
They would be considered contagious and infectious during that time as well. And typically symptoms last a few weeks. So 1 to 2 weeks is what symptoms last, but they could last longer, obviously with like those other populations, adults are immunocompromised.
Okay. And then you could have like future reactivations later on in life at any
But
point.
you'll never have a reactivation of chickenpox, but you could have a reactivation of shingles.
Okay. And then, sorry, one more question. And
No,
it's
this is
really
good.
specific, but for the dermatome aspect, like for shingles, if they do have a reoccurrence, and I don't know if you know this, but will they have it reactivated in that same area or will it always be different? Is there any like pattern to that?
Typically, it's the same dermatome. It's the dermatome that they had whatever dermatome they were hanging out in that ganglia. In theory, could it happen? Could you have a reactivation in another like local, close nearby dermatome? Probably. I'm not saying it's out of the edge of probability, but less likely. So most of the time, it's going to be that single dermatome that it was latent within because it spreads via that dermal nerve.
Oh, okay. So it just once it finds its like home, it kind of just hangs out
It
there.
hangs out there.
Okay,
Mhm.
awesome.
Yep.
Thank you so much.
Yeah, because it's hanging out on a nerve, right? So it's hanging out in the ganglia where the nerve roots or the like neuron bodies are, the cell bodies, and it's going to track down the axon to the surface. And so if there was a close by axon or neuron, like maybe kind of there's one on the face, like if there's a close by one that kind of accidentally jumped over, sure, it could hop into a different dermatome. But in the body, it'd be harder because those spaces are more spread apart and separated. So it typically is going to present on the same dermatome. Yeah, awesome. It's so good. I love it. So our other kind of torch condition that we see come up for our congenital infection is our 90% of pregnant females are already immune. So we often don't think about this for congenital varicella zoster virus infection. because it's pretty rare during pregnancy, but if you had a pregnant mom get a primary infection of VZV, varicella zoster, during pregnancy, you would have a greater risk of severe disease, particularly pneumonia. And this is, again, first try or first 20 weeks of pregnancy. There's a 3% chance of transmission to fetus. It's really small, but it is like a congenital varicella syndrome that's pretty horrific for the fetus, scarring of the skin, hypoplasia of limbs, central nervous system and eye defects, and oftentimes death is what occurs. So this is why we do that like initial pregnancy screen for pregnant moms, where we check for all of these kind of like viruses, viral infections, history of exposure, to make sure that they have had that immunity either via vaccine or via exposure themselves, to make sure that they're not at risk for passing it down to their fetus. And the TORCH infections refers to congenital infections of toxoplasmosis, others, which is syphilis and Hep B, rubella, cytomegalovirus, and herpes simplex. So those are the 5. So again, TORCH classically refers to congenital infections of toxoplasmosis, others, which is syphilis and Hep B, rubella, cytomegalovirus, and herpes simplex. But varicella zoster is a potential TORCH condition. It's just not in your acronym. So that's what TORCH stands for, if you were wondering. All right. Our HHV 6 and 7, they belong to the beta herpes virus subfamily of herpes viruses. The main target cell here is T lymphocyte cells, but B cells can also be infected. So they're hanging out and infecting T cells. HHV 6 infections associated with roseola infantum, which is the classical disease of childhood. And the majority of cases occur between 4 months and 2 years. And it's that spiking fever over 2 days, followed by a mild rash. The fever, though, could cause a febrile seizure. Again, encephalitis, again, is like your complication here. So those are your kind of beta family, HHV 6 and 7. T cells is the target, roseola infantum is the disease, and fever high enough to cause a febrile seizure. Those would be the pieces I'd keep in your brain for HHV 6 and 7. Now, cytomegalovirus, even though it's not an HH virus, it's part of the beta herpes virus subfamily of herpes viruses. So cytomegalovirus, we call this the most successful human pathogen because it can be transmitted vertically or horizontally, and typically with like little to no effect on the host itself. You can have transmission in utero, prenatally, postnatally, and once you're infected, you carry the virus for life, and it can be activated from time to time. If you were to test for it, you would find virions in urine and saliva when it became reactivated. Reactivation can also lead to vertical transmission, and if someone's had a primary infection, they could be reinfected from another or the same strain of cytomegalovirus. And the reinfection does not necessarily differ from clinical reactivation. So it's really hard to tell if someone's reactivating, reinfected, first time, 7th time. It can be challenging to note. In developing countries or developed countries, I hate this like terminology, but with a higher standard of hygiene, 40% of adults or adolescents are infected, and ultimately 70% of the population is affected. In other countries that maybe have less high standards of hygiene, we see over 90% of people affected. So really, like, the majority of people in the world have been infected with cytomegalovirus. So what does it look like? Well, congenitally, that's when we can be concerned. Congenital infection could result in cytomegalic inclusion disease. Perinatal infections, typically asymptomatic, and postnatal infection is usually asymptomatic, but you might have like kind of a mononucleosis type syndrome develop with fever, lymphadenopathy, and splenomegaly. So that could be a postnatal, like, to getting this as a normal child, adolescent, adult. Immunocompromised patients are prone to severe cytomegalovirus, like a pneumonitis, retinitis, colitis, and encephalopathy as potential complications. But most people that are healthy might not even know that they get infected with cytomegalovirus. And a lot of us, we would be tested and we would have antibodies indicating we've been exposed or infected at some point. But again, the concerning one would be congenital infection. That's where we can see potential microcephaly, small size for gastrointestinal age, issues with development that are potentially not conducive with life. As with all of these, it seems that's the nature. Almost always, if you have a reactivation or reinfection and it's not your primary infection, you would be asymptomatic and wouldn't know that you were reinfected. So your cytomegalic inclusion disease is defined as the isolation of cytomegalovirus from saliva or urine within 3 weeks of birth, and it's the most common congenital viral infection. The second most common cause of a mental handicap after Down syndrome, and it's responsible for more cases of congenital damage than rubella. So it's something to pay attention to. Microcephaly and intellectual disability, even epilepsy, are all potential central nervous system complications. You can have issues with vision, either retinitis or even just atrophy of the optic nerve. You could have deafness due to sensorineural deafness. You can see enlargement in the liver and spleen, and jaundice, which is due to inflammation of the liver, inflammation of the lungs, inflammation of the heart. What are we not seeing here, right? Thrombocytopenic purpura, hemolytic anemia, and late sequelae in individuals who are asymptomatic at birth could be hearing deficits and reduction in intelligence, potentially. So obviously, again, another reason that we test for viral disease, we test for viral exposure, and we try to avoid primary infections occurring at birth or right after birth. Epstein-Barr. Epstein-Barr has a lot of claim to fame, and we talk about it a decent amount, I think. Probably not enough. It belongs to the gamma herpes virus subfamily of herpes viruses, and there's 2 epidemiologic patterns seen with Epstein-Barr virus. We see 2 peaks of infection, the first in really young children, and the second in adolescents and young adults. And again, kind of like cytomegalovirus, about 80 to 90% of adults have been infected with Epstein-Barr at some portion of their life, whether they are aware or unaware. So if we did a smattering of antibody testing for all of us today, almost all of us would have Epstein-Barr virus antibodies, at least IgG, showing that we've had a previous infection. You can see by age 2 in some countries, almost all of children have been exposed. The virus is transmitted with saliva, particularly through kissing, but can be transmitted other ways that saliva can be in contact, so sharing drinks, things like that. And so we could see this transmission piece here, Epstein-Barr, oropharynx, through the epithelial cells, infecting a naive B cell. From here, dissemination throughout the blood. We can have that latent infected memory B cell that sticks around, can hit our lymphoid tissue, and then lead to a lytic infection where a B cell is essentially undergoing lysis because those viroids have bumped out of it. It moves out of the epithelial cells and sheds through saliva. So we can kind of watch the full cycle here and see where it's going to hang out, which is going to be in our B cells, our memory B cells. So it hangs out with us for life. Once we are infected, we're lifelong carriers, where typically low-grade infections are kept in check by our immune system. So we don't really ever see reactivation if you're healthy and you're in a normal, non-stress state. But you can sometimes even see people who are seropositive. You could check and see some low-grade virus replication, viral shedding, if you check the salivary gland or the saliva of people who were infected, seropositive at any given time. But EBV is able to immortalize B lymphocytes. So it's able to keep them alive forever, which is like crazy amazing and terrifying at the same time. We can, most EBV immortalized B cells, if they get to circulation, if they're, I mean, they'll be in the circulation, they'll constantly be kind of cleared by the immune system surveillance mechanisms. The immune system's like kind of constantly seeking them out to try to get rid of them, but it's sneaky, right? A virus hiding in our own cells, our body's going to recognize that as self tissue typically, and it's not going to target it for destruction. So the body, it doesn't ever fully clear this virus. We can see associations with EBV with other diseases where it can act directly on one or different cofactors. So some disease association, one we think of as infectious mono, another is Burkitt's lymphoma, nasopharyngeal carcinoma, lymphoproliferative disease and lymphoma in suppressed persons, and X-linked lymphoproliferative syndrome, as well as chronic mono. And I guess the last two are both AIDS associated. So again, compromised patients, but oral leukoplakia and chronic interstitial pneumonitis. I'd say by far the most common two asked about are infectious mononucleosis and Burkitt's lymphoma, but all of these are associated with Epstein-Barr infection. We'll go through our Epstein-Barr content, and then we'll probably take our 10-minute break, and we'll come back and finish viruses. So our infectious mononucleosis, primary EBV infection is typically subclinical in childhood, but in adults, there's a 50-50 chance that you'll develop infectious mononucleosis. So ideally, if you're exposed to EBV young, you might not develop an infectious mononucleosis later. But typically it's a self-limiting disease. We think about it as like kissing tonsils because there's lymphadenopathy, splenomegaly, and enlargement of our tonsils, so that like throat pain there. You can also in this instance see atypical lymphocytes being present in the blood. Complications really occur from if you're not paying attention and you have an enlarged spleen and then go and play a contact sport. So splenic rupture is the one that we counsel for the most. And then of course, because the tonsils do get so enlarged, if there could be pharyngeal obstruction if we aren't cautious. So you do have to pay attention to those pieces. Oftentimes you don't see this, but you could see a chronic infectious mononucleosis occur. This would lead to death eventually from lymphoproliferative disease or lymphoma. So it is not common, but there is an association there. And infectious mono takes a long time to fully recover. It's typically made by an antibody test or detection of Epstein-Barr virus, IgM. Now, Burkitt's lymphoma occurs endemically, especially in parts of Africa where it's the most common childhood tumor, as well as Papua New Guinea. It's still occurring endemically there. It typically occurs in children ages 3 to 14, and it will respond favorably to chemo if caught. It's restricted to areas with holoendemic malaria. So a malaria infection is typically seen as a cofactor. And you'll see that multiple copies of EBV genome, as well as some EBV antigens, can be found in these Burkitt's lymphoma cells. And patients with Burkitt's lymphoma have high titers of antibodies against different EBV antigens. So that's how we've gotten our association between the two. You would diagnose this with histology, and you can kind of see what these B cells look like. They have these little inclusion bodies in them. Almost all of the cases, the cells will express that IgM of EBV on the cell surface, the tumor cell surface. So there's this high association between the two. But I think the interesting point here is like malaria infection is a cofactor for this kind of picture of Burkitt's lymphoma. Okay, perfect. All right, maybe we can get through this one really fast. I'm trying to push us through the herpes viruses. So human herpes virus 8 belongs also to the gamma herpes viruses, subfamily of herpes viruses. It was originally isolated from Kaposi sarcoma cells, and now it's really associated, like you could say EBVs associated with Burkitt's. We could say HHV8 is associated with Kaposi sarcoma, as well as a couple other lesser malignancies, Castleman's and primary effusion lymphomas. HHV DNA is found in literally 100% of Kaposi sarcoma. So we will see this like direct association between the two. It's pretty low among the general population, but it can be higher in groups that are more susceptible to Kaposi sarcoma. And again, this is an old slide. I'm going to cross that out. Not true. Immunocompromised. There you go. That would be the correct. Immunocompromised. And unlike other herpes viruses, it does not have a ubiquitous distribution. So it is typically only seen in our immunocompromised folks. It could be immunocompromised for any way, shape, or form. We typically see it in our HIV patients. We can see it in cancer patients. We could see it in our autoimmune patients who are on autoimmune suppressive therapies. So that's really where we see HHV8. So HHV8, Kaposi sarcoma, immunocompromised. That's what you think about. Epstein-Barr, Burkitt's lymphoma, those two together. That will help us kind of like keep our mind and these diseases separate. Infectious mono is a viral disorder that can be debilitating and is characterized by which of the following statements? It's most prevalent in children less than 14. It's caused by rhabdo. The causative pathogen is Epstein-Barr. Effective persons respond to treatment with the production of heterophile antibodies. Ribavirin is the treatment of choice. Let's see, which one do we think? You said Epstein-Barr, you're correct. You got that in your brain. Adults who have varicella as children occasionally suffer a recurrent form of the disease shingles. The agent causing these diseases is a member of which of the following families? Herpes, pox virus, adeno, myxo, paramyxo. We said the herpes virus. Oh, the whole question turned. I got excited there. Whole question turned. Excellent. An immunocompromised person with a history of seizures had an MRI that revealed a temporal lobe lesion. Okay. Brain biopsy results showed multinucleated giant cells with intranuclear lesions. The most probable cause of the lesion is Hep C, herpes simplex, listeria, Coxsackie, parvo. Who causes that temporal lobe lesion? Yep, your herpes simplex. Remember that complication, that rare complication, but bad complication? Cytomegalovirus infections common. Which of the following statements best characterizes it? It can be transmitted across the placental barrier. It's almost always symptomatic. It can be cultured from red blood cells. It's not activated by immunosuppressive therapy. There's no specific therapy for cytomegalovirus. It can be transmitted. Oh, didn't spin. Oh, there we go. It can be transmitted across the placental barrier. Atypical lymphocytosis is most likely to be found in which of the following diseases? Encephalitis caused by herpes simplex, mono induced by Epstein-Barr, parvo, chronic hep C, rotavirus. Atypical lymphocytosis. It's going to be our mononucleosis induced by Epstein-Barr. Awesome. And then let's see, which of the following viruses is the leading cause of congenital malformations? There's only a few we've talked about so far. So cytomegalovirus is going to be our leading cause. Chickenpox, common disease of childhood. What virus causes it? Oh, we know this one, varicella zoster. That's easy peasy. Child has mono-like symptoms, but mono and EBV is negative. One of the causes of heterophile negative mono is, oh, yeah. Who's the other mono causer on the list? Cytomegalovirus. If it's not EBV that causes mono, it's cytomegalovirus. Malaise and fatigue with increased atypical lymphocytes and reactive heterophile antibody test is most commonly caused by the toxoplasma, Borrelia, Epstein-Barr, parvo, rubella. It's going to be your EBV again, atypical lymphocytes, malaise and fatigue. Your Burkitt's lymphoma, categorized by early antigen tests with a restricted pattern of fluorescence. Disease is caused by, we have this connection down now, Epstein-Barr with Burkitt's, the B and the B. And then this virus is detected by PCR in a variety of patients with nasopharyngeal carcinoma. This is another potential complication of this virus. Also EBV, remember it can cause like everything under the sun. All right, and that's where we are. So we're gonna pause here. We made it through herpes viruses, which is a huge success. I'm gonna see where we're at. Oh, I appreciate all of your guessing along. And I'll update that one slide that was wrong and I'll repost those notes so you have them. Excellent. Okay, questions, comments, thoughts?
I've been memorizing them with the with the number. And so I don't know if I should memorize it with the number like HV4 or just the name. What do you think?
I would know if they have a common name, I would know the name. If they don't have a common name, like HHV7, 6 doesn't have a common name, knowing them by the number is fine. but NPLEX will often test on the common name or the number if there's no common name, if that makes sense.
Okay, thanks.
Yeah. So if you know HSV 1 and 2, that's fine. That runs relatively easy to put into the brain. But for like varicella zoster, HHV 3, they'll probably always refer it to as varicella zoster. They likely won't say HHV 3. Same with cytomegalovirus, they probably won't say HHV 5. But for HHV 6, they would probably call that HHV 6. Epstein-Barr, they probably wouldn't call it HHV 4. So I'd say if they have a common name, know the common name. If they don't, totally fine to know it by the number. Knowing by the number is not going to harm you, but you might not make that connection if they state the name, if you memorize everything to just the number. Awesome. Perfect. All right, folks, 10 minutes off. We'll come back at 3:10. When we come back, we're going to pause from viruses and do some immunology because I want to make a switch to make sure we go through and cover all of our immunology content. And then we'll come back to viruses at the end if we have time. But we're going to, when we come back, this is a good pausing point. We're going to jump over to immuno and we'll do our immunology PowerPoint when we come back together at 3:10. So 10F. Okay. All right. Awesome. Thank you. And I will see you soon.